You are in the emergency department when a group of companions bring in their friend, a 16-year-old female. She has scars from acute and chronic intravenous drug use. She is acutely ill with a temperature of 40 degrees Celsius, heart rate 130, and respiratory rate 18. Her systemic venous pressure is elevated, and the jugular venous pulse contour is dominated by large CV waves that swell with each inspiration. Auscultation reveals a grade 3 out of 6 pansystolic murmur best at the lower left sternal border, radiating to the lower right sternal border, which accentuates to grade 4 out of 6 with inspiration. The liver seems to pulsate with each systole. Chest X-ray shows scattered focal white fluffy opacities. Which of the following is the most likely heart abnormality? Option A, tricuspid regurgitation. Option B, aortic valvular regurgitation. Option C, mitral regurgitation. Option D, ruptured sinus of Valsalva aneurysm. Option E, septic systemic arterial embolism. Take 10 seconds. Intravenous drug user with fever. Think infective endocarditis. The murmur is pansystolic at the lower left sternal border and gets louder with inspiration. Large CV waves on jugular venous pulse and a pulsatile liver. All signs point to the right side of the heart. Which valve? The correct answer is A, tricuspid regurgitation. This patient has infective endocarditis of the tricuspid valve causing tricuspid regurgitation. Intravenous drug use is the classic risk factor, and Staphylococcus aureus is isolated in the majority of cases. The pansystolic murmur at the lower left sternal border that accentuates with inspiration, known as Carvalho sign, is the hallmark of tricuspid regurgitation. Inspiration increases venous return to the right heart, increasing the regurgitant volume and the murmur intensity. The elevated jugular venous pressure with prominent CV waves reflects systolic backflow from the right ventricle into the right atrium and jugular veins. The pulsatile liver results from backflow through the hepatic veins during systole. The scattered fluffy white opacities on chest X-ray represent septic pulmonary emboli from right-sided endocarditis seeding the lungs. Mitral regurgitation is heard at the apex radiating to the left axilla and gets quieter with inspiration. Opposite of this murmur, it does not cause jugular venous pulsation abnormalities or a pulsatile liver. Aortic regurgitation is a diastolic murmur over the left chest. A ruptured sinus of Valsalva aneurysm presents as a loud diastolic murmur with hypotension and evolving shock. Key testing point. Intravenous drug use plus fever equals infective endocarditis, most commonly of the tricuspid valve, with Staph aureus as the causative agent. Tricuspid regurgitation presents with a pansystolic murmur at the lower left sternal border that accentuates with inspiration. Carvalho sign. Additional findings include elevated JVP with large CV waves, pulsatile liver, and septic pulmonary emboli causing fluffy opacities on chest X-ray. Follow for daily board questions.